So
go ahead.
I was gonna say it's showing me that I'm recording it, so maybe we can. Oh shoot! You know what the other issue is though? Oh my god. Okay, so the other problem is that it's not going to be an infinite amount of time because this isn't under the business thing. So should
we get started?
Just go ahead and get started. Yeah, sorry about that, man.
No, don't worry.
I'll chime in every now and then.
Until 7:03, I'm gonna give everybody 1 minute. I'm just gonna pull up my notes of how I want to introduce him.
Okay, sounds good.
And then we can go through it like you were saying.
Okay, and then hopefully this thing is recording on the side. I'm sorry, it's screwed up.
No, don't worry, man. I mean, we can only do our best until it all works out.
Yeah. All right,
brother. Yeah, what's up?
Let me know if you need anything else.
I appreciate you, homie.
Yep.
Assalamu alaikum. Can anybody hear me?
Wa alaikum assalam.
Wa alaikum assalam.
Excellent. Okay. So we have it so that everybody can just kind of get let in. They don't need to be let in themselves. So we'll just let them trickle in, but we can go ahead and get started just so we can try and maximize our time. So we are joined by Dr. A. He will go by Dr. A. MashaAllah, he's doing very well. He actually graduated from the New York College in 2015, went on to do his residency at Ascension Providence Park Hospitals in Metro Detroit. He is board certified in forefoot and rear foot surgery. It took him about 2.5 years to get his foot certification and about 3.5 to get his rear foot. And he has been practicing for the last 6 years, I believe, and has been doing very well. And I'll let him take it away from here. And this is going to be pretty interactive, and I'll let him speak more to that. But I think he wants it to be very interactive. So if you have questions, you want to chime in, don't hesitate.
Yeah, thank you very much. Can you hear me okay?
I can hear you perfectly. I know it says my name is Maqsood Ahmed. This is actually Jacob Nasser.
Oh, cool. Okay, good to know. Hope everybody's doing well this evening. Thank you for joining. Let's see. So, a number of my residents said they were going to try to join, so hopefully this can be a little bit more interactive. Let's see.
You should have access to share your screen, so
yeah.
let me know.
Yeah, perfect. Yep. So I will do that now. Oh. All right, so can everybody see my screen here?
Yes, sir.
Yes, all right, perfect. All right, so good evening, everyone. My name's Mohomad Al-Sawah, Dr. A, they call me. And I'm passionate about teaching. And I've been doing ABFAS exam prep for a number of years. I think I started in 2020. And so typically the way I do it, I every month or every other month we go through questions as well as some cases. And so there's not much for me to tell you about the actual exam. Everything that you need to know about the exam is actually right on their website. But I'm going to give you how I approach the exam. So the exam changed over the past couple of years, a little bit, but in many ways it's still the same. So again, this is going to be a quick overview, but I think you'll appreciate the way, because we're going to do some questions. I'm going to actually do the live questions on the lead, which are the circulating questions that are currently used by the ABFAS. And then I'm going to talk about strategy, particularly um, how I did it and how many of my residents did it over the years. I can speak to, I can speak to at least 12, 12 to 15 residents have done it this way, and with success. So many times folks will ask me, how'd you study? Did you read McGlamory? Did you go through journal articles? Did you do Coughlin and Mann, for example? And the truth is, I didn't do any of that in isolation. I did some of that, but only where I had gaps in my knowledge. And I particularly used a lot of uh, study resources to find out where the gaps are. For residents, you're going to find out um, where your gaps are with your in-training exams. So the way the exam is typically scored, it will give you a score, and um, it's particularly important to note where you scored poorly and where you did well. For example, complications, uh, medical management or medicine perioperatively, um, trauma, infection, tumors. All those things are important. So if you're constantly scoring lower in one area, you want to focus and you want to go back to the knowledge base. And particularly, the most important resource is the ABFAS website, and they have a lot of resources, practice exams, as we'll go through now, and updates. There's been some changes over the past couple of years in terms of the board making it a little bit easier to get board qualified, um, and uh, so and more affordable, to be honest. But I know there's a lot of talk now, particularly about the ABPM exam versus ABFAS. So I can tell you also practically, I'm on staff at 6 different hospitals. Um, 4 of them only accept the ABFAS certification for anything significant surgically. So I think with the CPME getting involved, there's probably going to have to be some type of agreement. But the ABFAS board will likely have a say, even if they combine to one board. And I think it's still important to go down this route, especially for residents. Sometimes residents will come and ask me, um, my thoughts are. So I think it's still important, especially as a resident, whether you depending on where you practice and what you're looking to do will determine where you pursue your certification. So for really for what I used and what I've been using for a number of years, in addition to and there are, I'm not a consultant for anybody, and this is completely bias free. But what I've been using and what my residents have been using and what I personally used are these 2 companies outside of the ABFAS, and particularly the board vitals for the discrete questions. And it's kind of nice because you have discrete questions. You can do them on your phone. on the computer. And the way I would do them, I would do the question and look at the answer right away. I was not using the questions, and I did thousands. I did all of them, at least twice. Um, as a resident, but I was not using the questions to um, see how I will do. I was using the questions to actually study, and sometimes you'll pick up a few things that say, wow, okay, I've gotten a number of these questions wrong. Now I need to go and review my knowledge base. For example, on interosseous muscles, something that's for the most part, memorization, or excuse me, or tumors. So I would do the question with board vitals, and I would look at the answer right away, and I'd read the explanation. You'll see me do this now when we go through the ABFAS live questions. Board wizards. I know there's a number of other platforms now and companies offering ABFAS. I can't speak to them, but this is one that it's not the same, but there's definitely some similarities between the real exam and this. They have many cases online. You can purchase them for residents. Typically programs, you go to the program director or coordinator, and they will actually pay for a subscription. And most of the time you have to share with other residents, but it's nice because you can practice. The one thing is the way that the ABFAS is set up. It definitely is relevant in terms of medical, legal, surgical decision making, and standard of care. So I haven't seen that with the other tests, to be honest. So that's important. So, but okay, let's jump in here. So I'll begin by doing the discrete questions, and I'm gonna want a bunch of volunteers. So, and we'll do these questions together, and you'll see how we'll approach each question. So I'll need a number of volunteers, please, that will be participating. We'll read the question, and then we'll talk about the choices and how we go through them.
Salam, I can volunteer.
Okay, is this who's this? Danny?
Danny, yes.
Danny, all right, brother.
How you doing?
Perfect. Who else? Let me see. Is Amin on here?
Yes, I'm here.
Okay, perfect. So you'll jump in. Anybody else?
All right. I'm happy to help as well, Doc.
All right, awesome. Yeah. So maybe we'll alternate, and this is timed. So we'll do this. These are very accurate because these are pretty much the circulating questions today. So likely you may see these on the in-training exam or the real exam. Okay, so all right. So who's going to take the first question?
I can go ahead.
All right.
Which statement regarding surgical repair of ankle fractures in geriatric patients is true? Soft tissue complications are more common. B, anatomic reduction is more difficult to achieve. C, post-operative casting increases the incidence of wound complications. Indeed, the presence of diabetes and obesity has no effect on the incidence of complications. And should I go ahead and guess, or?
Well, you're not gonna guess. You're gonna
Oh,
answer.
work through it. Sure. I think post-operative casting increases the incidence of wound complications as probably most relevant because geriatric patients usually don't have good skin integrity. Anatomic reduction is more difficult to achieve. I think that can be said for anyone. I don't think them being geriatric has anything to do with it. Same thing for the soft tissue complications. I mean, maybe because again they're a little more less healthy than a young person, so they could have more complications. And then the presence of diabetes and obesity has no effect on the incidence of complications. That's a false statement. I think it's kind of obvious that diabetes and obesity does have an effect on the incidence of complications in geriatrics. So,
Okay. All right. So we have a little bit time. So time is definitely an important with these exams. So, okay. So these are all good thoughts. Which statement regarding surgical repair of ankle is true? So we're gonna pick which ones are false and
mhm.
knock those out for sure. So the presence of diabetes and obesity has no effect on incidence of complications. This is completely false. Obesity doubles or triples the risk of complications, including DVT, wound problems. Diabetes is the same. Anatomic reduction is more difficult to achieve. I don't know. I mean, maybe, maybe we. This is not really okay. Soft tissue complications are more common. So
Maybe,
with
maybe.
geriatrics, it's a more. I would say is a little bit more general and a little bit more easy for me to pick A, because post-operative casting increases the incidence of wound complication. I don't know if that's true. Everyone casts differently. I use a lot of padding, for example, right? I mean, so and for that reason, and we'll go over it. Let me just answer it.
Okay.
So, do you agree that the first is probably the
Hmm.
best one?
Well,
Okay. So, and we'll see this. So, and this is exactly what I'm talking about when we learn from the questions. You're not just gonna blow past the questions. Um, we're gonna slice and dice them, and we're gonna uh, deconstruct them afterwards because this is how you really gain deep knowledge. Um, so, uh, and after they typically the the ABFAS and the board vitals. Um, does anybody know or have an idea of some of the newer platforms, or is this pretty much what everyone's using these days still?
Boards Blast is another one. They do a lot more case based, and I think they recently started having multiple choice questions.
Which one? Which one is that?
Boards Blast.
Boards Blast. Okay. Is this it or?
Yeah, so if you scroll down, you actually had the three different packages. So they've got the.
Oh, this is primarily for podiatry.
Yep.
Oh wow. Okay.
This was created by one of the temple attendings as well as a couple others.
Oh okay. All right. Excellent. So good. This is a new one. So yeah, like I said, I definitely um, definitely get your hands on as many questions as possible, because it's not really the questions, it's what you're going to get out of them afterwards. um, and so very good. So so this one for sure we know is false, number four. And number two, I think you hinted to number two. Number two, you said, there's so many different factors that affect number two. The comminution, where the fractures are. Some fractures are straightforward and they're not difficult to reduce at all in geriatrics. So I think that's not really so right away you can exclude 4 and 2, I would say, right? Um, in general, you're absolutely right. In general, casting unstable fractures definitely increases the risk of wound complications in general, right? Um, but there's this is really dependent on what kind of fracture it is. So, for example, if I tell you which is most likely to have a poor outcome in a cast with wound complications, a bimalleolar fracture, um, or a trimalleolar fracture, and just a distal fibular fracture. So definitely the more unstable fracture is just definitely going to have uh, more instability, more swelling, and uh, you know generally the soft tissue is going to be more of an issue for you to worry about, and that's why typically people frame those fractures, or like a peel-on fracture, they put them in a frame to monitor the soft tissue. So but they use this, and I don't like this question too much because you're absolutely right. The postoperative casting does increase the incidence of wound complications, as opposed to a splint, for example, or something a little bit more forgiving. Um, but this is um, is only true for a subset of fractures, right? It's not general. What they're looking for here is in general. So and it's I don't like this question. Um, but they're looking for what is the best answer. And generally, you'll see this as we go through and do more questions. There's always one or two answer choices that for sure you can cross out right away, and um, there's always two that are a little bit closer to each other. So down here, you'll see explanation: wound healing and infection are more common. Casting decreases the incidence of postoperative. Okay, so um, in general, casting postoperatively, even after a tendon repair or like an ankle implant, like an ankle arthroplasty, if you cast, what they're hinting to here is you're preventing motion. So when you prevent motion, you're going to decrease the risk of a wound problem. So they're assuming that it's a well padded cast. So they're taking
Okay.
yeah, they're taking this a different way. But I agree with you. And we may do a question later on that because the the way the folks write questions, it's written by many, and everyone submits questions, and so they go through them and they pick the um, the question pretty much has to go through several, but the questions are not really coming from the same mindset. That is it is a problem sometimes, uh, but again, you want to focus. You want to definitely. You have 3 minutes, right, or 2.5 minutes. So you want to definitely exclude right away the ones for sure no. You want to cross those out, and then you want to talk about it out loud and go back to the original question: which statement regarding surgical repair of ankle fractures in geriatrics is true? So uh, their reasoning they're reasoning that the postoperative casting decreases incidence of wound complications is actually the cast is protecting older folks. A lot of times you do a geriatric ankle fracture and you have to let them walk right away, um, in a walking cast, like a total contact cast. And the only difference between a walking cast and a non-walking cast is just the how much padding you have and how much casting material. So if you put an older patient in a boot, for example, they may not be compliant. The older population has more of incidence of um, peripheral neuropathy from a variety of causes, including just idiopathic neuropathy. So they may not feel it. So casting in some ways is protective as long as it's done right. But good conversation. Okay, we gotta get moving. Who's gonna take the next one?
I got it. Patient presents with sensations of paresthesia to the dorsal foot radiating to the lateral hallux, medial second digit, and first web space. A physical exam shows atrophy of the extensor digitorum brevis, muscle belly. What is the most likely diagnosis? Saphenous nerve entrapment, intermediate dorsal cutaneous nerve entrapment, lateral dorsal cutaneous nerve entrapment, or deep perineal nerve entrapment. So I think the giveaway here, I know we were going to try and rule things out, but I think this is just a basic memorization question, knowing what nerve it is. And we know what supplies the lateral hallux, and the medial second digit is going to be our deep perineal nerve.
Perfect. Yeah. This is like you said, this is a straightforward question. And, obviously we're not going to pick any of these. This is a straightforward question looking at pretty much the dermatome. Perfect. How would you treat this?
We can do a decompression of that nerve, specifically of that where it's going underneath that muscle belly.
Very good. Would you do a diagnostic block first to confirm?
Yes, and if I was doing the CBPS exam, I definitely would.
All right, great. Good job. All right, who's going to take the next?
I can do the next one.
All right.
All right, so regarding screw fixation of a medial malleolus fracture, which structure is at risk of injury during screw insertion? So first answer is saphenous vein. We have tibial nerve, posterior tibial tendon, flexor hallucis longus. So we're looking at the medial mal, so we're thinking of the structures running right next to it. So the closest one to it, you would have our Tom, Dick, Very Nervous, Harry. So it'd be posterior tibial tendon. Would be right beneath it. So I would say posterior tibial tendon.
Okay. How about the saphenous vein?
I think you can make the argument for the saphenous vein for sure.
And the saphenous nerve, which runs with the saphenous vein.
And saphenous nerve isn't an answer, so.
Yeah. So you guys are not considering tibial nerve or FHL?
No.
Because those are way in the back. Okay. All right. Cool. So it's funny. I've seen both of those structures injured. Both of those structures injured. The saphenous vein and nerve causing paresthesias after an ankle fracture, and then I've also seen not injury but irritation of the posterior tibial tendon from a washer. In the past, classically, the medial malleolus is fixed from where? Is it fixed from the back? Is it fixed from the central aspect of it or the anterior aspect of it?
When you say central, are you saying like central medial?
Yeah, exactly.
Yeah, I would agree with that.
This is a tough one. This is one of those like, okay, it's a poorly written question. I'm leaning towards one answer.
I would say saphenous vein.
Yeah, I'm leaning towards the saphenous vein just because most of the time you're fixing the anterior colliculus, right? Most of the time it's an anterior colliculus fracture. And we'll go over the anatomy after, but most of the time that's what's there. The posterior tibial tendon is running, it's running underneath. So, and from the back, Okay. Let's see. You see, I'm somewhat confident. I'm not completely, but because again, in practice, I've seen both injured, so very relevant. Okay, they wanted the posterior tibial tendon. All right, so this is where we go learning, right? So
Yeah, I was thinking like if you're like trying to perk it from just below it, you know.
yeah. I'm trying to see a typical like lateral, just because I want to see. Um, this is a good picture. This is a good picture. So typically, a medial malleolus is sort of like this. Sometimes it's two, three. Three usually is a sort of like a vertical type fracture where you're going to plate it. Um, and the reason why I said saphenous vein is this is typically your approach. Your approach is a little bit more anterior to evaluate the plafond and to get it perfect articularly. So typically the you're not really encountering per se the the popliteal tendon. That's why I because the saphenous vein and nerve run here. Um, all right. Well, I'm going to make some excuses for them as to why this is. So obviously, injuring the popliteal tendon has more of a serious consequence. The vein, you just tie it off. Um, it's not like it's a nerve where the patient is going to have permanent numbness and paresthesias, but um, that lies directly posterior to the medial malleolus. But again, most of the fractures that I've seen are in the anterior half of the medial malleolus, which is why I was going with this one. But I guess to make the argument to give them excuses for the tibia, this obviously is more serious of an injury, so I definitely want to avoid this. Uh, as opposed to this where you just tie it off. What's the consequence of injuring the saphenous vein? Hematoma, sure, but you're gonna tie it off. You're gonna see it. You're gonna see it bleed. Hopefully, you're closing wet or something like that.
Doc, would you ever look at these questions and say, okay, there's two answers that are talking about a tendon, so maybe it's between the PT and the FHL? I mean, I
No,
think that's kind of a bad way of looking at it, but
no, no, no. It's a bad way of looking at it. Don't do that. But um, the I think the the consequence with structure, saphenous vein. Okay, who cares? Yeah, the patient's going to end up with a little bit of swelling post-op if you knock out the saphenous, or for forever, really. But um, excuse me, but there's not much of a consequence. I've tied off many saphenous veins without any issues. This one, if you injure it, you have to repair it. And I've injured before. I've injured the posterior tibial tendon before on a medial mal takedown for a large OCD lesion that I repaired. And the patient did well. I had to repair the posterior tibial tendon. I had to, I lacerated, or not me, but the bone actually, as we were, distracting and moving things around, it lacerated like 50% of the posterior tibial tendon. So I had to repair it with fiber wire, end-to-end repair on 50% of it. The patient did well, didn't have any pain there. But I guess on a larger medial malleolar fracture, yes, for sure, this is at risk. But getting this question again, if I had seen saphenous nerve, I would still probably choose saphenous nerve. Just be honest. But yeah, some of these questions are, but again, I'm making excuses for them that this is more of a serious injury, serious structure to injure. All right. Who's going to take the next?
I got it.
Let's do it.
52-year-old male presents with a 6-month history of pain and swelling to the right ankle. No recent injury is reported. Based on the MRI, what is the most likely diagnosis? I think it says 3.4 millimeters is the size of that lesion that we're looking at.
I think it's 34 millimeters. 34, right? Because 3.4 is small.
Yep, that makes sense.
34 is 3.5. Yeah, so it's a large. Oof.
Yeah, got it with that image.
Yep. So 52-year-old. Okay, 6-month history of. Okay, they didn't give us any other history, huh?
So the answers are stress fracture of the talus, pigmented villonodular synovitis, AVN of the talus, avascular necrosis of the talus, or osteoarthritis. So I think based on the timeline that it's saying, it being 6 months, I would probably be more in the fact that it's history of pain and swelling, which are two of the key things that you're going to find with AVN, with chronic AVN. I would probably be saying AVN.
It's PNS.
100%, I agree. This is for sure AVN. The question is, what caused this AVN? And no recent injury. I mean, obviously, there's many causes.
Steroids.
Steroid use and amongst other medications.
As well as trauma.
Yeah.
This is PNS.
Yeah. And this is a straightforward one because they're giving you a picture, and you can see how pretty much the talus is for the most part gone.
Doctor, could this happen with that history just randomly? I mean,
It can. This guy could be just a construction worker, and he could tell you, I don't know. I have pain. I need to get back to my truck. I don't know. And his wife can tell you, I don't know. I need him just off of my back. I need him just to get better. And then you do a little bit of digging, and maybe his sister comes in one day and she's like, "Oh yeah, he used to always sprain his ankle. I would always see him in a brace in high school. He played football, and he sprained his ankle like 1,700 times. You know what I'm saying? Like, who there's so many different things that can cause this.
because, like, I mean, I guess with this question, they don't mention anything like that, and then that's the answer.
Right. This question is purely anatomy. This question is very similar to that deep cranial question. This question is, can you read an MRI? This is what this question is trying to say. Look at the tibia. Yes, there's some bone marrow edema here. Yes, there's some cystic changes, osteophyte formation, the front, the back. Look at the subtalar.
Even a little collapsing of that.
But look at the subtalar joint. Looks pristine.
Yep.
Look at the calcaneus. Looks pristine. Okay, the plantar fascia. Here's the Achilles. I don't see any massive synovitis around it. I mean, if they wanted to show you synovitis, they would have showed you obvious synovitis. But they're showing you collapse. They're showing you massive collapse and erosion, pretty much, of the talus. Now this is a T2 image. Everybody agree?
Yes.
This is a T2 image. On a T1 image, you're going to see a lot of this is dark. It would be AVN, so dysvascular. Right now, you can see some dark spots here, maybe some cartilage, but there's still some hyperintensity. So, but in another 6 months, this all may be dark, and the space between here and here is going to collapse further. So,
Doc, just as a heads up, we're got 18 minutes left.
I thought we were going until 9.
We can. We'll just have to send another link.
Okay. All right. Sorry. Yeah. Let's keep rocking out.
I'm not trying to shortchange you here, Doc.
That's close. Yeah. I mean, no, I know. We may have to extend it just because we're talking a lot about these. Okay. Who's gonna take the next?
I can do it. It's fine.
Okay.
A healthy 48-year-old male presents with pain, swelling, and redness to the second metatarsal phalangeal joint that has developed just after a dental procedure. Synovial fluid analysis shows 75% polymorphonuclear leukocytes. ESR is 32. CRP is 3. What is the most appropriate surgical treatment for this patient?
I just saw a patient this morning like this. Almost exactly the same, but not this, but this. So what's the diagnosis here?
It would be probably septic arthritis. So the options are irrigation and debridement, bone biopsy and culture and exchange the implant, partial second ray amp, preserve implant, irrigation and debridement and bone biopsy and culture. So it looks like the implant has failed.
Exactly. So I wish I can. I wish I can zoom. I wish I can zoom in, because obviously you want to look for any loosening of the implant, and obviously the toe is already, yeah. So in a classic case, you would want to see if the implants.
And the last answer was explantation, irrigation and debridement, bone biopsy and culture, and antibiotic spacer.
Okay.
So I'm leaning towards the last one. I mean, like we were talking about, we're definitely going to take out this partial second ray amp. I would say that's not really something we want to go ahead and do. The fact that they had the recent dental procedure is a high likelihood that they got an infection in that joint implant. That's always a high risk after an implant.
Does it matter how soon after the surgery?
I think it's I want to say 1 year, but I could be wrong. It could be 2 years.
Absolutely. Yeah. The sooner. Yeah. I mean, the sooner you are from the procedure, the more likely you are to have a. I agree with number 4, and number 4. So obviously, you're not gonna take this out, implant, and put another one. Before actually getting a good culture-specific antibiotic going.
Right.
The one thing that's missing here is synovial fluid analysis shows 75%. Okay, but what about the culture? You're not going to send some of this fluid for culture, or not culture, but gram stain, for example.
Right.
It's in 1 day you can have a gram stain, or 2 days you can find out what's if there's anything growing. This gives you an idea of what to expect. But sure, yep, good job. What would you do? How would you manage this afterwards?
So after what we did?
Yeah.
Once everything is negative, then we can consider doing like reimplanting that implant.
Yeah.
Because I don't think you want to fuse that second ray.
I've done 6 of them.
Okay.
But
I stand corrected.
But no. But usually it's combination with first.
Understood.
So look at how the first is leaning over. So that needs an Aiken to straighten it out.
Right.
And then I agree. Another maybe another implant, but I'd wait until Cedrate and ES, everything is back down to
Calm
normal.
down. Yeah.
Yep. So, but this is it's a tough one. If the index procedure here has been more than a year, this may call for an MRI to delineate how much bone is involved potentially. Does that make sense? Because you're not going to have post-surgical changes. So all good. Nice case, very good case. Okay, we already talked about these. All right, let's continue.
Which finding is an indication for use of an interosseous suture button construct for a Lisfranc injury? Purely ligamentous rupture, greater than 5 millimeters of displacement, intra-articular, or homolateral dislocation. So I think what they're looking for here with interosseous suture button, more commonly you're going to do that if it is ligamentous rupture. And then to argue greater than 5 millimeters of displacement, you probably want to fuse that because you're going to get some post-traumatic arthritis. Same thing can be said about intra-articular fracture. And I don't think a homolateral dislocation is really going to, determine whether you use a suture button or not.
Very good. The intra-articular fracture, depending on the comminution, you may not be able to fuse right away. How would you treat that?
You could do a plate.
What kind of plating technique would you use?
Depending on the level of comminution, maybe just a bridge plate to make sure you have it out to length.
Good for you. That's exactly right. Bridge plate. All right, good. Next one. Try to.
Anybody else want to jump in, or you want me to just keep rolling?
Yeah, whatever. I mean,
which location of a plate will result in the most compressive forces across the first tarso-metatarsal fusion site with weight bearing? Which location of a plate will result in the most compressive forces across the first TMT with weight bearing? Medial, dorsal, plantar, or dorsomedial? So the compressive forces, the most compressive forces would be plantar, because of the convex nature of the bone.
That's exactly right. So so this is a plantar plate, for example, and when the patient bears weight, what's going to happen is you're going to, when the patient bears weight, they're going to bear weight here and here, right? And you're going to, this midfoot fusion site is going to want to gap plantarly. But if you have a plate on the bottom, rather than any plate gapping, you're going to get compression dorsally. You're going to get compression dorsally. Okay. So if another question I remember is where are you going to get most of your compression with a plantar plate with weight bearing, and that's dorsal. So that's how that works. The only thing is you got to get around the TA, and you got to put some screws within the TA5. I've done this a few times, but this is exactly right. This is exactly how that works. All right, we may not be able to get to the cases.
He actually sent another link, so that will start in 5 minutes, I believe.
Oh, okay. All right, we'll rock maybe one or two questions.
We could even just switch over now if you wanted to do that.
Let's do this last question because he's out of time.
Okay.
You started it already. We can just do this last one and then we'll hop.
Yeah. Okay.
35-year-old male is being treated for chronic pain and swelling of the second metatarsal phalangeal joint. Based on the image, which surgical procedure is most appropriate? So looking at that image, we can see there's flattening of the met head, concerning for avascular necrosis.
You only gave us AP, huh? Okay.
So
Yeah, just let's look at other deformities.
So the met parabola looks okay.
Mm-hmm. Good job. Yeah. Met primus varus, pretty significant. There's some metaductus. The rear foot looks somewhat aligned. Okay.
Open plantar plate repair, dorsiflexory wedge osteotomy, joint replacement with implant, or second metatarsal head resection. So I would be between the last two options. joint implant with replacement or second med head resection.
Okay.
And I think based on the med parabola, I would prefer.
Okay. So all right. So why did you jump to med head resection?
If we have avascular necrosis of that joint, it may not be amenable to a I didn't realize the 35-year-old. I skipped over that.
Yep.
But it may not be amenable to a implant if there's avascular necrosis in that joint.
For sure. So the surgical treatment for this is always going to be initially this.
Okay.
Always. And then it's not really a replacement. So this is the answer that they're pretty much looking for. And once you fail this, that's when you go into either a replacement, and the replacement in the second MPJ is not really a true replacement. It's more like a spacer, It's just to hold the second toe. It's really a spacer.
Okay.
So this one versus this one, obviously there's problems, transfer lesions. You're gonna have to do that. You may have to do, and usually I've done it. You have to do floating osteotomies.
Okay.
And you have to watch the patient and whatnot. So, if there was more involvement, and they tell you, oh, it's a 55-year-old or whatnot, then perhaps you can think about it. Or if they tell you they failed osteotomy, but typically the reason why people get AVN, the way this happens is the joint collapses, but there's actually decent cartilage plantarly. So if you do a V and bring the cartilage that's on the bottom back up, it can work. The problem is getting fixation, and sometimes you use some crossing trimmet pins, sometimes crossing screws. But fixation is difficult for sure. But it can work because typically the cartilage on the bottom is actually a lot better than the one on top.
Would you ever fix this with a plate?
It's a good question. Very good question. Truthfully, I've only done one, and I fixed it with trimmet pins.
Okay.
And the patient, did okay, but then moved to another state. So I don't know. She probably, but that's a great, that's like a mini plate for sure. That's probably a really good. I should have probably done that, to be honest with you. But you can get bicortical fixation from the top. I used a trimmet pins from Arthrex, and they actually held pretty well. So, and then I K-wired the toe. So, all right, let's get the other link.
Before you okay, so the other link is in the chat there. Everyone, let's just take 5 minutes and hop over there, and then we'll get started on that one at 8 o'clock. Sorry for the confusion with all the links here, but go ahead and click that second one there. Yep.